Chapter 23, General Surgery. The objectives are to identify the anatomical regions and sections of the abdominal wall and describe common procedures to fix abdominal hernias along with the basic pathology of gastrointestinal system. The terms of this week will also cover the terms for next week. The body is separated into different compartments divided by membranes, muscles, and other connective tissues. In the abdominal cavity, where you have your abdominal organs such as your stomach, lungs, liver, and the pelvic cavity, which has the reproductive and GI systems, along with the retroperitoneal, which is the space between the peritoneum and the posterior abdominal wall, which contains your kidneys, adrenal glands, and ureters. The abdomen is divided into 4 sections called quadrants. The right upper, which contains most of the liver, gallbladder, duodenum, the head of the pancreas, hepatic flexure of the colon, and part of the ascending and transverse colon. And the left upper, which contains the left lobe of the liver, your stomach, spleen, body and tail of your pancreas, the splenic flexure of the colon, and part of the transverse and descending colon. And then you have the right lower with the cecum, appendix, your right ureter, right ovary, right fallopian tube, right spermatic cord, and left lower with part of the descending colon, the sigmoid colon, left ureter, left ovary, left fallopian tube. Your abdomen is then divided into 9 regions: the right and left hypochondrium, the epigastrium, right and left flank, umbilical region, and right and left iliac fossa, and the hypergastrium. Tissue has 5 layers: the skin, subcutaneous fatty tissue, fascia, muscle, peritoneum. The skin layers are usually sutured together in 3 groups: the peritoneum, the fascia and muscle are usually closed as one, and skin. Suture materials for each layer are strong enough to approximate the layers after it has been surgically cut, but fine enough to cause as little trauma as possible. These are technical points that contribute to wound management and a successful surgical outcome. The Hasselbalch's triangle includes the rectus abdominis muscles, inguinal ligaments, and the inferior epigastric vessels. The spermatic cord in males follows the inguinal canal and contains the spermatic fascia, the cremaster muscle, which raises and lowers the testes to keep sperm at the optimal temperature, the genitofemoral nerve, the ductus deferens, which is also called the vas deferens, which carries the sperm into the urethra, lymph vessels, and the testicular vein and artery. Abdominal incisions are named according to their anatomical location. Most general open surgeries use the midline approach. The perimedium, which is a vertical incision about 4 centimeters lateral to the midline on either side, above or below the umbilicus. The subcostal incision, oblique incision, which follows the margin of the rib. Right or left flank, seen in kidney and ureter surgery. Inguinal is made in the lower lateral abdomen area. McBurney used to access the appendix, and the phalansteal is the incision commonly seen in C-sections. Abdominal wall hernias are when tissue protrudes through a weakness in the abdominal wall. The weakness is caused by a congenital abnormality or previous surgery and injury. There are different types of hernias depending on the location. Surgery for hernia repairs can be performed at an outpatient or a main OR. It can be done either open or laparoscopic. The patient is usually in the supine position and a Foley is inserted to decompress the bladder. General or spinal anesthesia is usually used. Ultimately, all hernias are caused by a combination of pressure and an opening or weakness in the muscle fascia. The pressure pushes against the organ or tissue through the weakness or opening, and sometimes the muscle weakness or opening is present at birth. More often it's acquired later in life. Congenital versus acquired defects. presents as an obvious swelling beneath the skin of the abdomen or in the groin. It may disappear when you lay down. There's a heavy feeling in the abdomen that is sometimes accompanied by constipation and blood in the stool. To repair the defect of the hernia, braided synthetic suture and mesh are commonly used. The principle of the mesh is to provide a bridge of strong material over the weakness in the abdomen and release some of the tension on the tissue edges. During the remodeling phase of healing, scar tissue will fix the space where the mesh is. For case planning, you need to know if the procedure is going to be open or laparoscopic, if they're going to close a defect with just suture, or if they're going to use mesh or a combination of the both. And if they are going to use mesh, you want to have different size options available. You also want to know what position the patient is going to be in. Most likely it's supine. Incisional hernias are a result from a previous abdominal incision that did not completely heal and may require mesh to fix a defect. Incisional hernias develop if the wound becomes infected during the healing process. In some cases, a fistula develops. That's a tract or tunnel that develops in the lining of the epithelium. Ventral hernias are often called incisional hernias because it also results from surgery. These type of hernias can be caused by obesity, excessive strain on the tissue that pull on the tissue fibers apart, and the abdominal wall becomes weak. Surgical repair, the patient is usually in the supine position and the abdominal scar is removed and saved as a specimen. The edges of the previous incision are trimmed and old sutures are removed along with any adhesions. Synthetic mesh is applied and the layers of the tissue are closed with interrupted suture. Strangulated or incarcerated is when the tissue that is protruding from the hernia becomes swollen and squeezed. Immediate surgery is required so that the tissue does not lose blood supply and die. It's called ischemia and necrosis. Indirect hernias is when the abdominal viscera slides into the inguinal canal from the deep inguinal ring. This is what they check for when they have men turn their head and cough. Open surgical technique is the patient is in the supine position and a right or left inguinal incision is made. The layers of the abdominal wall are closed. The layers of the abdominal wall are incised and retracted. The spermatic cord is dissected and retracted, and the hernia is opened. The contents are pushed back into the abdominal cavity. The hernia sac is ligated, sutured, and then a synthetic patch is used to fix a defect. Then the abdominal wall is closed. A direct inguinal hernia is protrusion of the abdominal or inguinal tissue directly through the transversalis fascia. Usually occurs in older men. A direct hernia comes out directly forward from the posterior wall of the inguinal canal. Umbilical hernias are a defect at the umbilical ring, seen in infants and adults. Umbilical hernias are hernias around or under the umbilicus or belly button. These can be common for babies, but often resolve themselves without surgical intervention. They are not very common in adults, but when you do see them, they're most likely incarcerated. Femoral hernias occur most often in females. Multiple childbirth, obesity, and inherent weakness in the abdominal wall can create a weakness in the fascia that can allow herniation of the abdominal tissue into the canal. The femoral hernia sac will be sent as a specimen once it's dissected out. Most likely, the hernia appears as a bulge below the crease line of your leg. It runs a high risk for strangulation and incarceration. A splagellin hernia occurs just outside the outside border of your six-pack muscles. It's more common in women than in men. Usually around 50 years old, you'll start to see those. They're very hard to diagnose because of the location. The most often when you're having an exploratory laparotomy is when it is found. Your esophagus is a tubular structure that extends from the pharynx to the stomach. This is the path that food follows when you swallow. And an average adult is about 10 inches long. The stomach is located right underneath the diaphragm in the upper left part of the abdomen. The stomach has three parts: the upper portion, which is called the fundus, the middle section, called the body, and the antrum, which is a distal portion. The wall of the stomach contains an outer serosal layer and two inner layers and a submucosal layer called rugae. The submucosa secretes hydrochloric acid and pepsin for the breakdown of proteins and carbs. The two orifices and sphincters provide continuity between the esophagus and stomach. The cardia, which communicates with the esophagus, and the pylorus, which communicates with the stomach. Attached to the greater and lesser curvature of the stomach is the omentum. It is a vascular sheet of connective tissue. It provides warmth and protection to the viscera. Whenever the stomach is removed, a part of the omentum must be divided from its attachments. The omentum is very vascular. That's why we use the clamp, tie, cut method. It's basically a fat pad with blood vessels. Whenever you remodel or change the stomach, the omentum has to be changed also. The omentum is where most men store their fat. The small intestine is the proximal portion of the intestinal tract. It extends from the pylorus to the proximal end of the large intestine. It has three anatomical sections: the duodenum, ileum, and jejunum. The small intestine has three tissue layers: the inner mucosa, submucosa, and serosa. The duodenum is about 8 to 10 inches long. This is where the food that has been broken down and liquefied goes. It's called chyme. The pancreatic duct and common bile duct from the liver drain enzymes into this portion of the intestines. The jejunum is about 9 feet long and connects with the ileum, which is about 13.5 feet long. They are suspended from the abdominal wall by a sheet of vascular tissue called mesentery. That supplies blood and lymph to the lower sections of the intestine. The inner surface of the small intestine has finger-like projections called villi, which increase the surface area of the intestinal lumen and contain blood and lymphatic vessels. The small intestine ends at the cecum, which is the first part of the large intestine. The large intestine extends from the distal ileum to the rectum and divided into 5 sections: the ascending colon, transverse, descending, sigmoid, and rectum. The colon is about 5 feet long in an adult. The long axis of the colon puckers called hatra, which is a result of the longitudinal muscle contraction called tenae coli. The first section of the large intestine has a blind pouch called cecum, and at the terminal end there is a slender tube called the vermiform appendix, which has no purpose and can become infected and cause pain. The ascending colon extends up from behind the right lobe of the liver. The transverse colon crosses over the abdomen to the left behind the stomach. The descending colon extends down on the left side of the abdomen and terminates at the sigmoid colon, which lies in the pelvic cavity. The sigmoid colon terminates at the rectum. The primary function of the large intestine is absorption of water and electrolytes and the formation of fecal waste. Essential resident bacteria in the colon decompose undigested substances and produce gas waste as a product of fermentation. It also produces vitamin K and certain B vitamins, which are absorbed into the body. The distal 4 to 5 inches of the intestine is the rectum, which ends at the anal canal. It is lined with folded tissue. There are two sphincters in the anal canal which control the release of feces. The internal, which is composed of involuntary smooth muscle, and the external, which is a striated voluntary muscle. The opening of the canal is called the anus. Confirming issues with the GI system is usually done by imaging studies such as MRI, ultrasound, and CT. Contrast mediums are used to outline the GI structures. There are also blood and metabolic studies, as well as physical examinations. Biopsies and visual exams of the inner surface of the intestine and stomach are performed to confirm or rule out cancer and provide tissue for further tests. The patient is often in the supine position. Exceptions are procedures that require access to the perineal area. Then they are in low lithotomy. The patient's arms are placed on arm boards, and the operating table is tilted in a Trendelenburg or reverse Trendelenburg, depending on the anatomical exposure required. For GI surgery, clamps should be non-penetrating and atraumatic. Depending on the size of the patient, long instruments may be added. Sharp dissection is performed with Metzenbaum scissors or a Bovie and harmonic scalpel. Babcocks are used to grab the intestinal tissue, and smooth or vascular forceps are used for suturing mucosal layers. GI procedures require sutures or surgical staples for resection and anastomosis for bowel mesentery or anomentum. Suture closure is done in 2 to 3 layers. Fine observable sutures on a tapered needle are used to close the mucosa and submucosa. The outer serosal layer is closed with a fine interrupted silk or synthetic material on a tapered needle. Large vessels are ligated with suture clips or a vessel sealing instrument. Anastomosis is a joining of two hollow structures by suturing or staples or both. Usually terms that end in ostomy mean anastomosis. In all procedures involving the intestine, special precautions are taken to prevent contamination of the instruments and supplies. This is known as a bowel technique. After the bowel is closed, all contaminated items are removed from the field, and everyone involved changes their gloves and possible gown depending on the situation.